accurate.
We aren't just talking about medicine.
Yeah.
We're talking about the physiology of pregnancy and the incredibly delicate art of treating two patients at once, the mother and the fetus.
It really is a unique situation in the medical world. I mean, usually you have one patient, one body, one set of kidneys and liver to worry about.
Right.
But here you have two distinct biological systems that are intimately connected, sharing a blood supply, yet they have completely different needs and vastly different vulnerabilities.
It sounds like a logistical nightmare. And I think the common perception, maybe the one you, the listener, might have in the back of your mind, is that pregnancy is this time of total abstinence.
Oh, absolutely. Don't touch anything.
Don't take anything, don't touch anything, just suffer through the headache or the allergy because everything is dangerous. Just grin and bear it for 9 months.
That is the common perception, yes. But the reality we are diving into today paints a much, much more nuanced picture.
Okay.
The mission of this deep dive isn't to scare you away from medications. It's to decode how pregnancy actually changes the human body's operating system. And I mean a total
overhaul.
And how medical professionals navigate that risk versus benefit landscape. Because, and this is the key takeaway right at the top, the goal isn't just avoiding drugs. It is about optimizing health.
Optimizing health sounds nice, but if I'm a pregnant woman, my instinct is to avoid anything chemical.
Which is completely understandable. But consider this. An untreated condition in the mother, whether that's epilepsy, asthma, or depression, can often be far more dangerous to the fetus than the medication itself.
How so?
Well, if the mother isn't healthy, the environment for the fetus is compromised.
Yeah.
A seizure, an asthma attack, these things can deprive the fetus of oxygen, so we have to balance the scales.
Okay, so we're balancing scales on a moving ship. Let's talk about the ship itself, the engine room, or the physiology, because I was blown away by this stat in the research.
I think I know the one you mean.
During pregnancy, maternal blood volume and cardiac output don't just go up a little bit. They increase by 30 to 50%.
It's massive. It's not a subtle shift.
That is huge. That's not a bump. That is a physiological overhaul. I mean, if I suddenly had 50% more blood in my body right now, I feel like I'd explode.
Your body adapts, of course, but it creates what we call a dilution effect.
The dilution effect.
Yeah, think about it like this. If you think about the body as a tank of water, and you suddenly add 50% more water, the concentration of anything you pour into that tank is going to change.
Okay.
This fundamentally alters the pharmacokinetics, which is just a fancy word for how drugs move through the body.
So let's unpack that. How does this extra fluid affect the medication you might take? Does it just water it down?
In a way, yes. Because the plasma volume is so much higher, the concentration of the drug might be lower than you'd expect in a non-pregnant person. But it gets much more complicated than just dilution.
I figured it would.
We also have to look at albumin.
Albumin, that's a protein, right, in the blood.
Right. Albumin is a protein in your blood that acts sort of like a sponge. It floats around and holds onto drugs as they travel through the bloodstream.
Like a taxi serves?
A taxi, a sponge, yeah. When a drug is bound to albumin, it's inactive. It's just riding the bus. It's only the free drug, the stuff floating around on its own, that can actually interact with your cells and do the work.
Okay, so albumin is the sponge. More sponge means less active drug.
Correct. But here is the twist. During pregnancy, plasma albumin concentrations actually decrease.
Wait, so you have more blood volume but less protein sponge. How does that work?
Exactly. The liver creates albumin, but it just can't keep up with that massive expansion of plasma volume. So you have fewer sponges relative to the amount of fluid.
So, hold on. My brain is trying to connect the dots here. If there are fewer sponges, there is more free drug floating around. So does that mean the drug is stronger?
Theoretically, yes. You have more active, unbound drug. But, and here is where your head might spin,
oh boy,
because there's more blood flow to the liver and kidneys, the body clears that unbound drug faster.
That sounds completely contradictory.
It is a paradox. You have a situation where the active portion of the drug might be higher because there's less albumin to hold it, but the kidneys are working overtime. Filtration increases significantly, so they are flushing out of the body much faster than usual.
That sounds less like science and more like chaos. How on earth do you calculate a dose in that environment?
It requires a lot of vigilance. It's a push and pull.
Yeah.
You might need a higher dose to account for the clearance or a lower dose to account for the free fraction. It depends entirely on the specific drug.
Okay, and that's not even all of it, is it?
Not even close. We haven't even mentioned body fat.
Right. Body fat increases during pregnancy. I assume that acts as a storage locker for some drugs.
Perfectly put. Drugs that are lipophilic or fat-loving have a larger volume of distribution.
More places to hide.
They have more places to hide in the body tissue, which means they can stay in the system longer, leaking back out slowly over time.
So the physiology is just shifting sand. But let's talk about the stomach itself. I think everyone knows morning sickness is a thing, but the data suggests the actual chemistry of the stomach changes.
It does. For one, pregnancy slows down gastric emptying. The food and the drugs sit there longer.
Okay, that makes some sense.
But also, the gastric pH increases, meaning the stomach becomes less acidic.
And I assume that messes with how pills break down.
It specifically affects the absorption of weak acids and bases. If a drug relies on a highly acidic environment to dissolve properly, it might not work as efficiently because the pregnant stomach is just more alkaline.
Okay, so the mother's body is a constantly changing variable. But then there's the bridge between the two patients, the placenta. I think I've always imagined the placenta as this fortress wall. You know, nutrients pass through, but toxins and drugs just bounce off like arrows.
That is a very comforting image, but it is a total misconception.
It's not a wall.
The placenta is not an impenetrable wall. It's much more like a sieve or a filter. And whether a drug gets through depends on physics and chemistry, not magic.
So what are the rules of entry? Who gets past the gatekeeper?
The first rule is size. It's just simple physics. Molecular weight is measured in Daltons. If a drug is small, under 500 Daltons, it transfers readily. It walks right through the door.
Okay, under 500 is a pass. What about the big guys?
If it's between 600 and 1,000, it crosses, but slowly. But if it's a big molecule greater than 1,000 Daltons, it barely crosses at all.
And that's a key distinction.
It's a crucial distinction. It's why insulin and heparin are the MVPs of pregnancy therapeutic. Exactly. Insulin is huge. It stays in the mother's blood to manage her sugar, but it doesn't cross over to the fetus in any significant amounts, so we can treat the mom without accidentally dosing the baby.
That makes perfect sense. Physics as a safety feature.
Correct. The second rule is solubility. Lipophilic drugs, those fat lovers we mentioned, cross the placenta much easier than water-soluble ones.
Why is that?
The cell membranes of the placenta are made of lipids, so fat-soluble drugs just slide right through. Unfortunately, this includes a lot of common drugs like opiates and many antibiotics.
So we've got the machinery. Now let's talk about the timeline. Because one of the biggest takeaways I got from this deep dive is that when you take a drug, matters just as much as what you take.
Absolutely. We call this the calendar of risk. The susceptibility of the fetus changes dramatically depending on the week of gestation.
The research outlines a few distinct phases. The first one is called the all-or-nothing period. This is the first 2 weeks post-conception. That sounds ominous.
It sounds dramatic, but it's biologically accurate. In those first 2 weeks, the cells are undifferentiated. They are just beginning to divide.
Okay.
If there is exposure to a teratogen, a harmful substance, one of two things usually happens. Either the damage is so severe that the embryo doesn't survive, resulting in a loss of pregnancy, often before the woman even knows she's pregnant. Or the repair mechanisms are so robust that the embryo fixes the damage completely. Because the cells aren't specialized yet, they can replace each other, so the pregnancy continues as if nothing happened.
So it either ends or it's fine. There's no middle ground where you have a minor defect.
Generally, yes. It's binary. But then we enter the danger zone.
Right.
The period of organogenesis.
This is days 18 to 60.
Right. This is when the organs, the limbs, the heart structures are actually being built. This is where exposure causes structural anomalies. If you introduce a disruption here, you aren't just slowing growth. You are altering the blueprint while the house is being built.
And the notes list some heavy hitters here.
Yeah.
Methotrexate, lithium, retinoids, thalidomide.
And coumarin derivatives, like warfarin. These are agents that can cause profound physical defects if introduced during that critical window of days 18 to 60.
Then we move into the second and third trimesters, the growth phase. The risk changes here, right? We aren't worried so much about an arm not forming, but other things.
Exactly. The structure is built. Now it's about growing and refining. Exposure here can affect the central nervous system, cause growth retardation, or unfortunately, fetal death.
And that's not all.
No, there are also specific drug mechanics that become risky only later in pregnancy.
This brings us to NSAIDs, like ibuprofen and tetracyclines. The guidelines are very specific that these get riskier as time goes on.
Yes. NSAIDs are a classic example of why details matter. In the third trimester, we strictly avoid them.
Why, though? What changes?
The reason is mechanical. There is a blood vessel in the fetal heart called the ductus arteriosus.
Okay, what does that do?
It acts as a bypass. Since the fetus isn't breathing air, it doesn't need to send all its blood to the lungs. The ductus arteriosus shunts blood away from the lungs to the rest of the body. It's vital.
I see.
But NSAIDs work by blocking prostaglandins, and prostaglandins are what keep that vessel open.
So if you take ibuprofen in the third trimester,
You risk closing that vessel prematurely before the baby is born. That causes high pressure in the fetal lungs and can lead to heart failure.
wow,
So ibuprofen might be okay occasionally in the first trimester, but it is absolutely contraindicated in the third.
that is a very clear red line. Let's shift gears to the proactive side. Preconception and those everyday hurdles. If you are planning a pregnancy or even just in that phase of life, there is one supplement that seems non-negotiable.
Folic acid, without a doubt. It is the single most effective intervention we have to prevent neural tube defects, things like spina bifida.
And the recommendation is what, about 0.4 to 0.9 milligrams a day?
That's the standard dose,
Yeah.
yes. And you want to start this before you get pregnant?
Because the neural tube closes early. Right, like really early.
Very early. By the time most women realize they missed a period and take a test, the neural tube is already closing or closed. If you wait until the positive test, you might have missed the window.
But there's a nuance here for high-risk groups. The dose changes drastically.
Drastically. If a woman is on certain seizure medications or has had a pregnancy affected by neural tube defects before, that dose jumps massively. We go from roughly 0.8 milligrams to 4 milligrams per day.
They're milligrams.
That's a tenfold increase in some cases, but it's necessary to overcome the drug interactions and protect the fetus.
Now let's talk about vices. Smoking. Obviously the advice is stop. But quitting is hard, and cold turkey doesn't always work. The research goes into some detail about nicotine replacement.
It does. And behavioral therapy is always the first choice. Always. But if you need nicotine replacement, the delivery method matters. We prefer intermittent forms like gum over continuous patches.
Why? Nicotine is nicotine, isn't it?
It's about total exposure time. A patch delivers nicotine constantly, 247. Gum delivers it in a spike, then it clears. You want to minimize the total time the fetus is exposed.
So what if you do use the patch?
Then there is a specific protocol. Take it off at night.
16-hour protocol.
Exactly. Don't wear it for 24 hours. When you sleep, take it off. Give the fetus an 8-hour holiday from the vasoconstriction of nicotine.
That's a really practical tip. Moving on to the daily grind symptoms. Pregnancy isn't always glowing. Sometimes it's constipation, reflux, and nausea.
It's very common. Physiology again, everything slows down to extract more nutrients for the baby. For constipation, we always start with lifestyle. Fiber, fluid, exercise.
And if that doesn't work,
Stool softeners, or PEG, which is polyethylene glycol, are okay, but you have to avoid castor oil and mineral oil.
why castor oil? I feel like that's an old wives' tale remedy to induce labor.
Which is exactly why we avoid it. It acts as a stimulant laxative, but it can also stimulate uterine contractions. You don't want to accidentally trigger labor just because you were trying to fix constipation.
Noted. No castor oil. And reflux. That heartburn feeling.
Same idea. Lifestyle first. Small meals, don't eat 3 hours before bed. If you need a pill, antacids with aluminum, calcium, or magnesium are fine. Sucralfate is also fine. But avoid sodium bicarbonate and magnesium trisilicate.
Then there's the big one. Nausea and vomiting. The morning sickness that often lasts all day.
The bane of the first trimester. Again, simple stuff first. Ginger is actually clinically recognized as safe and effective.
Ginger, like ginger ale.
Ginger capsules, tea, chews, small meals, acupressure bands.
But if that doesn't work, I know people who are completely debilitated by this.
Then we move to pharmacology. The first line option is a combination of doxylamine, which is actually an antihistamine, and pyridoxine, which is vitamin B6. It's very safe and sold over the counter.
Okay, and if that fails,
We might move to metoclopramide or ondansetron, but then there's the most severe form.
hyperemesis gravidarum, the can't keep watered down version.
That's a medical emergency. It can lead to severe dehydration and electrolyte imbalances. In those cases, steroids like dexamethasone might be used as a last resort.
But there's a risk.
There is. We have to be careful. Early use of steroids is linked to a slightly increased risk of oral clefts. So it's a serious decision, not a first choice.
This leads us perfectly into the high-stakes section of our discussion. Chronic conditions. This is where the two patients dilemma really gets intense. Let's start with epilepsy.
This is one of the most challenging areas. The statistics are, they're frightening. Malformations are 2 to 3 times more likely in women taking anti-epileptic drugs, or AEDs.
Okay, if I'm a patient and I hear 3 times more malformations, my instinct is to flush those pills down the toilet immediately. Why take the risk?
That is a very human instinct, but in this specific case, it's a trap. You have to ask the darker question. What happens to the fetus if the mother has a grand mal seizure?
I assume the mother gets hurt, maybe falls. But is the baby cushioned?
It's not about the fall. During a tonic-clonic seizure, the mother stops breathing properly.
Right.
If she stops breathing, the fetus is instantly hypoxic. That lack of oxygen is often far more damaging to the developing brain than the medication ever would be. The risk of uncontrolled seizures is worse than the risk of the drug.
So you have to treat it. But how do you make it safer?
Strategy. First, monotherapy. Using one drug is much safer than a cocktail of drugs. Polytherapy increases the risk significantly.
And second?
Second, avoid the bad actors. Valproic acid is the one specifically called out as high risk for neural tube defects and cognitive issues. We try to avoid it if at all possible.
And are there safer bets?
Carbamazepine and lamotrigine appear to have a better safety profile, but again, it's all about planning, optimizing the dose before conception if possible.
Let's look at asthma. The theme here seems to be breathing is good for the baby.
Very much so. Uncontrolled asthma leads to decreased oxygen in the blood, which is bad for fetal development. The risks of the medications are much, much lower than the risk of the mother not breathing.
So stick with the inhaler. Yes, albuterol is the standard rescue inhaler. For maintenance, inhaled corticosteroids like butanide are preferred. We do not want women suffering through asthma attacks out of fear of the inhaler.
Depression is another major one. And it's tricky because stopping antidepressants can lead to relapse at a really vulnerable time.
Relapse rates are high, and maternal depression itself has negative outcomes for the pregnancy. Poor nutrition, missed appointments, high stress.
So what's the risk of the drugs themselves, SSRIs, for example?
Generally, SSRIs are not considered major teratogens. They don't cause structural defects. However, we have to be aware of something called prenatal antidepressant exposure syndrome.
What does that look like?
If SSRIs are used late in pregnancy, the newborn might have some respiratory or cardiac issues, or withdrawal symptoms, jitteriness, irritability. It's usually transient, meaning it goes away, but it's real.
Any specific drugs to watch out for?
There is a specific warning on paroxetine regarding a potential for cardiac defects if used in the first trimester. So we try to avoid that one if we can.
So the rule is lowest effective dose.
Lowest effective dose for the shortest necessary time. But often, treating the depression is the right choice for the family. A healthy, functioning mother is the best thing for a baby.
Let's talk about HIV. The medical progress here is incredible. The goal is simple: stop transmission.
And we are very good at this now. The standard antiretrovirals, or ARVs, are usually continued. Interestingly, this is one area where we want drugs to cross the placenta.
Really? I thought we wanted to keep drugs away from the fetus. That seems counterintuitive.
Not here. Zidovudine is a key agent because it has high placental passage. We want it to get to the fetus. We want it to be there, guarding the baby against the virus.
That's a fascinating inversion of the rule.
It is. And the delivery protocol is specific too. Usually a C-section at 39 weeks to minimize exposure to maternal blood during labor. And if the viral load is high or unknown, we give 5 zidovudine during labor itself.
Moving on to hypertension and diabetes. Two conditions that are becoming more and more common in pregnancy.
Let's start with hypertension. We have a few different kinds: chronic HTN, gestational HTN, and then the scary one, preeclampsia.
Preeclampsia is high blood pressure plus protein in the urine, right?
Correct. And it can escalate quickly to involve other organs. Prevention is interesting here. The research notes that low-dose aspirin, just 81 milligrams started after 12 weeks, reduces the risk of preeclampsia by 17%.
This baby aspirin, that seems too simple.
Just baby aspirin. It improves blood flow to the placenta. Calcium supplements also help a bit.
But if blood pressure gets dangerously high severe HTN, we have to treat it immediately.
If it hits 160 over 110, we are in stroke territory for the mother. We treat that aggressively. The safe drugs are labetalol, hydralazine, and nifedipine.
And what are the drugs we absolutely cannot use? Because I know a lot of people take ACE inhibitors for blood pressure.
ACE inhibitors, ARBs, and renin inhibitors. These are standard blood pressure meds for non-pregnant people, but in pregnancy, they are a major no-go.
A no-go because?
They can cause renal failure and death in the fetus. If a woman is on an ACE inhibitor and gets pregnant, she needs to switch immediately. It's an urgent change.
Now, if preeclampsia progresses to seizures, that's eclampsia. How do we stop those seizures?
Magnesium sulfate. It is the gold standard for preventing and treating eclamptic seizures. We actually avoid standard seizure meds like diazepam or phenytoin in this specific emergency context. Magnesium is what works.
Let's touch on diabetes, whether it's gestational or GDM or pre-existing.
First line is always diet and monitoring. Always. But if we need drugs, insulin is the champion.
Because of that physiology lesson we had earlier.
You got it. Remember our discussion about molecule size?
Right. Insulin is the giant molecule. It's over 1,000 daltons.
Exactly. It doesn't cross the placenta well. So we can control the mother's blood sugar without dosing the fetus with insulin, which could cause the baby's blood sugar to crash after birth.
What about oral pills? Metformin, that's much easier than injections.
Metformin and glyburide are alternatives, yes. But metformin does cross the placenta. It's less studied than insulin and generally less favored, though it is used when insulin isn't an option or is refused by the patient. Insulin remains the gold standard.
Okay, let's do a rapid-fire round on acute care. You wake up with a headache. What do you take?
Tension headache, acetaminophen, Tylenol. Safest bet, hands down.
Ibuprofen.
First or second trimester, maybe okay for short-term use. Third trimester, absolutely not. Remember the ductus arteriosus.
Urinary tract infections. This was surprising to me. The guidelines say you treat them even if there are no symptoms.
Yes, this is called asymptomatic bacteriuria.
Wait, you treat it even if she feels fine. Isn't that over-prescribing antibiotics?
In a non-pregnant person, yes, we might let it ride. But in pregnancy, the ureters are dilated, everything is sluggish. Bacteria can travel up to the kidneys very easily.
And that's a problem because...
An untreated UTI can turn into pyelonephritis, a severe kidney infection, which can trigger preterm labor. So yes, we treat it aggressively to protect the pregnancy.
And the antibiotics. Any to avoid.
Cephalexin is safe. Nitrofurantoin is okay early on, but avoid it after week 37 because it can cause hemolytic anemia in the newborn. And stay away from fluoroquinolones and tetracyclines entirely.
Sexually transmitted diseases. High stakes for the baby here.
Syphilis is the big one. Penicillin G is the only choice.
What if the mom is allergic to penicillin?
It doesn't matter.
What do you mean it doesn't matter? You can't give a patient a drug they are allergic to.
Right.
That sounds like malpractice.
It sounds like it, but in this case, the alternative congenital syphilis is so devastating that we don't have another good option. There is no other drug that works as well, so we perform desensitization.
Which means what, exactly?
We admit her to the hospital and give her tiny microdoses of penicillin, gradually increasing the amount over hours, essentially tricking her immune system into tolerating it just long enough to get the treatment in.
Wow.
It's a high-wire act, but it's absolutely necessary.
Okay, and for herpes?
The concern is transmission during birth, which is very dangerous for a newborn. So we use suppressive meds like acyclovir or valacyclovir near term to prevent an outbreak, hopefully allowing for a vaginal delivery.
Speaking of birth, let's get to labor and delivery. Sometimes labor starts too early. Preterm labor.
Defined as labor between 20 and 37 weeks. When this happens, we use drugs called tupolytics. But here's the thing. The goal isn't necessarily to stop labor forever. Often, we can't.
So what is the goal?
The goal is to buy time.
Buying time for what?
Usually just 48 hours.
Wait, you go through all that trouble stopping labor, the drugs, the monitoring, just to buy 2 days? That seems like a lot of effort for 48 hours.
It does sound small, doesn't it? But in neonatology, 48 hours is an eternity. It is the specific window we need for corticosteroids like betamethasone to work their magic.
Magic meaning what? Growing lungs.
Exactly. It speeds up the production of surfactant in the fetal lungs.
Surfactant. That's the lubricant, the stuff that keeps them from sticking.
Think of it as a coating inside the lungs. Without it, a preemie's lungs are like uninflated balloons that stick together every time they exhale. It takes huge effort to reinflate them.
I see.
With surfactant, they stay open, they can breathe. So those 48 hours allow the steroids to kick in, which can be the difference between a baby in severe respiratory distress and one that's breathing comfortably.
So the tocolytics, the drugs that stop labor, aren't the cure. They're just the pause button so the steroids can do the real work.
Precisely. And the pause button is tricky. We used to use terbutaline a lot. It's a beta agonist, but the FDA actually slapped a warning on it because it causes significant heart risks for the mother.
Like what?
Tachycardia, arrhythmias. It should only be used as an injectable for that short 48 to 72-hour window and with extreme caution.
So what do we use instead?
Magnesium sulfate is used, though truthfully, the Cochrane Review, which is a major analysis of medical data, questions whether it actually stops labor effectively.
But it's still used.
It is, because it does help protect the fetal brain, which is called neuroprotection, so it still has a role. Nifedipine, a calcium channel blocker, is actually very common now because it has fewer side effects.
There's also Group B strep. I know this is a standard strain.
Yep, checked at 35 to 37 weeks. It's a bacteria that lives harmlessly in many women, but if the baby picks it up during birth, it can cause neonatal sepsis, which is life-threatening.
And the fix is simple?
Very. If the mom is positive, she gets IV penicillin during labor. Simple intervention, huge impact.
When it comes to induction starting labor, we use oxytocin.
Oxytocin causes the contractions, yes. But you can't just hammer a closed door. You have to unlock it first. That's cervical ripening.
How do you do that?
We use prostaglandins like dinoprostone. There is also misoprostol.
Misoprostol? I've heard of that.
It's effective and cheap, but it's powerful. The research flags a risk of uterine rupture. If a woman has had a previous C-section, misoprostol is generally too risky because the scar on the uterus might tear under the force of the contractions.
Finally, the baby is here. We move to lactation. The mechanics change again.
They do. Now we aren't talking about a placenta, we are talking about milk. Drugs enter milk via passive diffusion. It's all about concentration gradients.
Does the sieve concept still apply? Are the rules the same?
Similar principles. Drugs that are highly protein-bound stay in the mom's blood and don't get into the milk as much. Large molecules stay out. High lipid solubility, those fat lovers get into the milk easily because milk has a high fat content.
But there's another factor.
There is.
pH, acid versus base again.
Breast milk is slightly more acidic than plasma. So drugs that are weak bases can get into the milk and then get trapped there. We call it ion trapping.
Trap.
They cross over, become ionized because of the different pH, and then they can't cross back.
So the concentration in the milk could actually be higher than in the blood.
In some specific cases, yes.
Yeah.
But for most drugs, the amount that reaches the baby is very small, often less than 1% of the maternal dose.
So what's the strategy for a breastfeeding mom who needs medication?
Timing is key. Take the med after a feeding so the level in your blood peaks and starts to drop before the baby eats again.
And if supply is low, relactation.
Metoclopramide is the drug mentioned. It blocks dopamine, which increases prolactin, the milk hormone. It can increase supply, but it should be used sparingly, usually only if non-drug therapies like pumping and proper hydration fail.
So we've covered a massive amount of ground, from the stomach acid changes to the placental filter to the specific risks of epilepsy and hypertension. What is the big picture here?
The big picture is that pregnancy transforms the body's chemistry. The volume, the albumin, the kidneys, everything changes. And navigating that requires respecting the all-or-nothing phase, the structural risks of the first trimester, and the growth risks of the third.
And the risk-benefit analysis, that seems to be the core theme.
That is the core. Treating chronic conditions like epilepsy, HIV, and hypertension is vital because a healthy mom is the absolute best protection for a fetus. We cannot fear the medicine cabinet. We have to understand it.
It's a bridge we have to cross carefully.
Yeah.
And that leads me to a final thought. We spent a lot of time talking about the placenta as a barrier or a sieve.
Right.
But hearing all this, specifically about how we want HIV drugs to cross or how we treat the fetus with steroids through the mother.
It raises a fascinating possibility.
Right. We often view the placenta as a defensive wall. But what if we thought of it as a gateway? The challenge for the future isn't just avoiding harm. It's developing drugs that are smart enough to specifically target the mother without crossing that bridge for things like maternal pain or nausea.
Or the reverse.
Or conversely, drugs designed specifically to cross it to treat the fetus directly for genetic conditions or infections before they are even born.
That is the frontier. Precision medicine, not just for one patient, but for the dyad. Treat the mother, treat the baby, or treat both with intentionality.
A fascinating thought to end on. Thank you for listening to this deep dive into therapeutics in pregnancy.
Thank you.
Stay curious, and we'll see you next time.